Kirollos Hanna from the University of Minnesota Medical Center and Mayo Clinic School of Medicine will now deliver our Clinical Corner presentation sponsored by Rigel. This month's Clinical Corner discussion is an overview of Tavalisse, tablets, and adult immune thrombocytopenia. Kirollos.
Thank you so much, Stephen. I'd like to start off by saying it's an honor to be here with everybody. I'd like to thank NCODA and Rigel for setting all this up. And with that, Stephen, we can go to the next slide. So for those of you that might treat patients with ITP, idiopathic thrombocytopenia purpura, or also referred to as immune cytopenia, over the past decade, several years, we have not really had much change. Just recently, we had the approval of fostamatinib or Tavalisse, really allowing patients to have a different novel mechanism of action. So before we get into Tavalisse, we'll give a little bit of background on the actual disease state for those that might not be familiar with it. When you look at the studies of ITP overall, the epidemiology is really limited. You look at the disparity and the number of incidents across the country, it ranges anywhere from 4,000 up to 10,000 newly diagnosed patients annually. The ASH guidelines, the American Society of Hematology, identifies ITP under 3 stages. You have your newly diagnosed, persistent, and chronic. These are further defined really by the time from diagnosis. So your newly diagnosed is anywhere from diagnosis to 3 months, where the persistent is anywhere from 3 to 12 months, and then your chronic patients, the ones that require extensive therapies, are generally longer than a year, and they have persistent thrombocytopenias. Overall in the US, we have roughly about 50,000 to 60,000 cases. When you look at the bottom at the demographics, there's a slightly higher incidence in females over males, really no racial predominance, and roughly 80% of the population that has ITP is those chronic patients, those patients that have had the disease for over a year. We can go on to the next slide. When we talk about, we can go on to the next slide, Stephen. Are we there? Yep, okay, thank you. My computer was a little slow. When we talk about ITP, the causes of ITP, there's really 2 causes. You have immunologic destruction of platelets, but then there are also secondary causes that can lead to this autoimmune disorder. Generally in children, they develop ITP secondary to potentially viral infections, and oftentimes they recover without any treatment, whereas in adults, we tend to see the prolonged, persistent cytopenias due to this autoimmune destruction, as well as some certain drug exposures or chemical exposures. There have been studies that have shown not only an immunologic destruction of platelets, but also a decrease in platelet production. So you have these 2 underlying mechanisms of the actual disease. We can go on to the next slide. Again, when we talk about the ASH guidelines, they were last updated in 2011, which shows you, when you look at some disease states, you have guidelines that are updated several times a year, but unfortunately ITP, we have not really had much advances. They recommend that treatment, they recommend first several treatment options, which include corticosteroids, IVIG, rituximab, as well as splenectomies or the thrombopoietin receptor agonists, which I will refer to as TPO-RA from now on. And when it comes to selecting therapy for patients, it's really going to be tailored to each individual patient, potential side effects that they may have had from the medication, such as rituximab, how fast you want to see a platelet recovery, and also the presence and severity of bleeding. So how fast we want to address this issue. But for most patients, first line is long courses of corticosteroids in combination with IVIG. And later down the line, you'll see splenectomies, rituximab, and the TPO-RA utilized. We can go to the next slide. With that, we'll move on to Tavalisse's approval. So Tavalisse was approved April 17th of this year, and it's the first and only spleen tyrosine kinase inhibitor. I will refer to this as SYK inhibition from now on. It's indicated for the treatment of thrombocytopenia in adult patients with chronic ITP who have had an insufficient response to a previous treatment. So only one single treatment, and then they would be eligible to try Tavalisse. It does have a major metabolite, R406, which inhibits the signal transduction of Fc-mediated immune response and the destruction of the platelets. And shortly we'll look at an illustration that demonstrates the novel mechanism of action. We can go on, Stephen. Just some general information about Tavalisse. It comes in 100 milligrams and 150 milligram tablets in 60 count bottle sizes. The recommended initial dosing clinical trials is that patients are started on 100 milligrams BID, irrespective of meals, so with or without food. And then after a month or 28 days, if there is an inadequate platelet response, which is defined as a platelet count of 50,000 or more, if patients are not there, you should increase the dose to 150 milligrams BID. When you look at the package labeling, there are no recommendations for baseline hepatic or renal impairment. It seems as though impairment doesn't affect the pharmacokinetics. We can go on to the next slide. Here is this illustration that demonstrates this novel mechanism of action. So as you see to the left, in ITP, these platelet antibodies bind to the platelets. Macrophages throughout the body in the spleen and the liver will recognize these platelet antibody complexes. And then you will see FC-mediated destruction of platelets via activation of the FC receptors. And then later down the line, you see this SYK signaling pathway that's also activated. So it's believed that Tavalisse inhibits this SYK activation, which ultimately decreases the platelet destruction and thus the novel mechanism of action. We can go on, Stephen. The approval of fostamatinib was based on 2 clinical trials, FIT1 and FIT2, which were 2 identical trials. We'll look at some baseline characteristics for patients. So again, there were 2 identical double-blind placebo-controlled phase 3 trials. They enrolled a total of 150 patients with chronic ITP who had an insufficient response to previous treatment. The patient characteristics in the trial were really demonstrated a difficult to treat population. And by that, I mean these patients had long-standing ITP. You look at the time since ITP diagnosis, the population had roughly, the median was 8.5 years since diagnosis. Many had several attempts at prior therapies. There was a median of 3 unique prior therapies, and as well as several patients, almost half the patients had platelet counts that were typically associated with severe bleeding episodes. You look at the very bottom, these patients had platelet counts of less than 15,000, generally requiring transfusions because they were very acute. In addition to that, most common prior therapies also included the standard care, which was corticosteroids, IVIG, your TPO-RA. So it was a very good demonstration of what we see in patients. We can go on to the next slide. Here you see the breakdown of FIT1 and FIT2. Again, they were identical studies. They randomized patients to receive fostamatinib at a 2-to-1 ratio. So it was Tavalisse versus placebo, randomized in a 2-to-1 ratio, and patients received therapy for 24 weeks. If they had an inadequate response at 4 weeks, they were allowed to increase the dose to 150 milligrams BID. And then at the 24-week mark, the patients who continued to respond to Tavalisse could go on to an extension trial, the FIT3, which was also an open label extension trial. But for the sake of time, we will not go too much into detail. But patients did maintain a response. There are durable responses seen from FIT3. We'll go on to the next slide, please. So the efficacy and primary endpoints that were used in the FIT1 and FIT2 were the stable platelet response was defined as a platelet count greater than 50,000 on at least 4 of the 6 visits between response defined as 1 or more platelet count of 50,000 or greater within the first 12 weeks of initiating therapy. We can go on to the next slide. Prior to talking about the actual results, we'll look at some of the safety data that was associated. As you would expect with any other TKI, Tavalisse, fostamatinib although it's a novel mechanism of action, it's still a TKI at the end of the day. And the safety profile was very similar to what we're used to. So diarrhea, hypertension, nausea, dizziness, those were the most common adverse events. And the package label which I will refer you to just for the sake of time, discusses specific dosage reductions, which we'll also take a very quick look at, but it does indicate specific dosage modifications for patients that may have experienced adverse drug reactions. It is important that for patients who are initiating therapy, that they're informed that periodic monitoring of blood pressure, liver enzymes, CBCs will be required should they require dosage interruptions, reductions, or discontinuation potentially of therapy. We can go on to the next slide. So some of the efficacy data, which is really, really exciting and led to its approval, the overall response occurred in 43% of patients on fostamatinib versus 14% in the placebo group. These patients also had a stable response. It was 17% versus 2% on placebo. So you look at these patients who are trying a second-line therapy, they're having strong, significant, clinically significant responses. Again, the overall response was 1 or more platelet counts greater than 50,000 within the first 12 weeks, and then the stable response was 4 of the 6 visits between weeks 14 and 24 were greater than 50,000. So it's really, really exciting. We can go on to the next slide. In that subset of patients that actually had a stable response, 82% of patients actually had a stable response that was maintained for a year on Tavalisse, which is, again, something, often these patients are requiring several lines of therapy, and this is really good data for those patients, those are chronic patients that require more treatments. So it was very exciting, and as demonstrated here by this graph. We can go on to the next slide. When we talk about dosage reductions, as I briefly mentioned, there are specific toxicities that the package labeling outlines, as just hypertension, hepatotoxicity, diarrhea, and neutropenia, and how to dose reduce should 3 or 4 toxicities occur. This graph to the right, or figure to the right, kind of demonstrates that for you and how doses can be reduced. We can go on to the next slide, Stephen. So again, just to summarize everything, the stable response seen with Tavalisse was 17% versus 2% with placebo. The median platelet count that patients were reporting was 95,000. The overall platelet response was 43%. Placebo. Again, the median platelet count was 49,000. The median time response was roughly 2 weeks, which is also very good. The response varied. The response among patients with various types of prior therapies, there was still a response seen despite the number of therapies that they've had. And if you remember the characteristics they've had, most patients at least tried 3 treatments. So this really gives us a new therapeutic option for patients once they've progressed on anything. And again, once they progressed on at least 1 therapy. So if your patient has only tried corticosteroids, they are candidates and would be eligible for Tavalisse therapy. And then the company also provides extensive support for when it's needed. And we can move on to the next slide. So the Rigel ONECARE is a great resource. We can move on to the next slide, Stephen, please. Rigel ONECARE provides resources for patients, for clinicians, physicians, financial support, patient education, side effect management, and it's all available through Rigel and available on their website should anybody choose to utilize this for resources. And with that, I will open the floor to any questions that anybody may have.
Thank you so much, Kirollos. So what we'll do now is we'll open the lines Q&A chat. We'll take a look, see if any questions come through. In the meantime, if anyone has any questions who joined via the app or joined us by computer, please feel free to raise your hand, and we can also unmute your mic if you're willing to ask a question in person. So we'll open it up for questions. Kirollos, we have one, just came in through the Q&A box. An NCODA member asked, what do you think is the main takeaway of this presentation or, Tavalisse in general?
So personally, I think it's very, very exciting when you have disease states that have not had much growth in several decades, and we still don't know the resolution, that we see this growth and research growth in novel mechanisms of action and these new targeted therapies have an impact for patients. Tavalisse, actually, there are ongoing clinical trials that are actually evaluating Tavalisse at earlier settings as well. So we don't know what's going to come of it, but it's very exciting right now that we know, we know that patients, a large subset of patients, progresses after one line of therapy. We know that, if you remember on the very beginning of this presentation, 80% of patients made up that chronic population, which again is having the disease for longer than a year. And it provides that novel mechanism of action that we know works, and we've seen responses and a reduction in bleeding episodes. So it's very, very exciting. I'm excited to kind of see what will come of it in the next years, as well as, potentially, hopefully, or maybe frontline indications, depending on maturation of data.
That's great, Kirollos. Thank you. And thank you again for your presentation. What we'll do is, if anyone does have any questions, we will reserve some time toward the end of the presentation. So feel free to, again, ask a question in the Q&A box or raise your hand at the end, and we can always come back to the presentation. As always, if you have any questions regarding anything discussed today, please feel free to email contact@ncoda.org, and we'd be more than happy to follow up with you. So thanks again, Kirollos.